So really, really pleased that today to be introducing Mel Robertson, Nurse Consultant, and Helen Maws, Nursing Informatics Coordinator from City Hospitals Sunderland. And they will be taking us through the e-prescribing and bedside medicines verification session. So they'll be leading through all the slides. We've allowed time for questions at the end, but if there's anything that strikes you during the course of the presentation, can you submit these as we go along using the chat function? And you'll be able to access that on the left-hand panel of the screen for those who aren't familiar with webinars. If you send your question as a private message to Katie Wardell, who's the host, and then we'll read out all the questions at the end of the presentation. You can also use that chat function if you want to get in touch with us because there's any technical problems, and we'll see what we can do to support you. Hopefully that's clear to everybody. And without further ado, I'll hand over to Mel and Helen, who will take us through the presentation. Many thanks.
Thank you. Hello everyone, my name is Mel Robertson. I'm a consultant nurse in oncology and more recently have stepped into a role as Chief Nursing Informatics Officer as part of my overall role, and I've got Helen with me here today. So we'll go through the presentation and then I'll move over to Helen to do a little demonstration of the MV side of things. Just to look at the screen here in the capabilities section in the middle with regards to the GDE project, this presentation covering the medicines management and optimization element, just so that you know where we're talking or what we're talking about. A little bit of background demographics about Sunderland Hospital. We serve a population of approximately 340,000 and a little wider for some of the specialist services that come into the hospital, so up to a population of around 860,000 for certain specialties such as urology. We've got around 804 acute beds, so you'd probably say we're a decent medium-sized hospital. The inpatient episodes over the financial year 2016 to 17 came to just under 56,000, with day cases just under 60,000, outpatient attendances 385,000, and ED attendances 152,000, just over. So reasonably busy. We're talking today about electronic prescribing and also bedside medicines verification, and the electronic prescribing system for us is not new at all. We started it probably around 13, 14 years ago with our older version of our current system. And we started that in all of the inpatient areas. We made the exception of ICCU and the neonatal intensive care unit that would have found that quite challenging at first. We then rolled out outpatient prescribing in 2010, and when we updated to a different version of our current provider in 2013, it allowed us to move forward with ED and ICCU, and we've moved over to oncology in 2015, which is when I became more involved in the IT work. Bedside medicine verification, or BMV, is much more new to us, and that's been a project that we've been working on this year over a number of months earlier this year. So we started off looking at electronic prescribing a lot earlier, with the aim of by 2005 getting to level 3 with regard to the NHS electronic patient record strategy. Before that, we did a paper prescription. It's quite old. I haven't been able to put my fingers on how many patients this was actually looking at, so I'm sorry it's not wonderfully helpful, but there was a number of very striking audit queries that came out of the audit. One prescription literally had no surname on it whatsoever, with just a first name. 12% of the records that were looked at the time had no allergies, and actually an incorrect dose of medicine was noted on 15% of the prescriptions that were audited. There was no prescribed signature for 5 of the patients, and it was absolutely impossible to identify who was actually cancelling the medication and whether that was done appropriately. Back in the time, just putting a great big line through a prescription was about all you would do, quite frequently, to discontinue something, so there was no clear auditable trace of who'd made that decision, when and why. So there was an awful lot about the paper prescribing system that we knew we really needed to improve, and we were keen to move forward with that. We did have back then some pre-printed protocols, whilst the majority of things were just paper-based, and obviously still paper-based, but we did have protocols which were very specific, so there was only patient identifiable details and some loose calculations needed to be added, as things like GKI, infusions, warfarin and chemotherapy. So we had some degree of areas to make things safer, but a huge area of risk, really. So the approach that we took was to be quite multidisciplinary and try to get as many people on board with the project team as possible, and that tends to be how we do work at Sunderland. We've got a relatively small IT system, but a wider range of clinical staff that get involved at different levels, either on certain projects for quite a significant amount of time, and sometimes just in the background in their normal job as super users. That tends to be how we do roll things out. There was a lot of staff road shows and ward meetings, and we tried to raise the awareness that electronic prescribing was coming along, and we decided to pilot just on one medical ward initially, and it was quite a slow rollout from that point of view. It took us around 18 months to get all of the inpatient areas up and running, and that excludes the areas that I mentioned early on that weren't moving over to electronic prescribing at the start. So quite a long project that required an awful lot of input into. We've done BMV quite different in that we've done some end user training for key nursing and medical staff in a sort of trainers way, and we've encouraged them to go back to the clinical areas and do cascade training to people that they work with, and made sure that the right staff who were the super users were on duty as each of the shifts changed, to be able to explain how things were going and give a little bit of supervised practice at the time. So the rollout's been an awful lot quicker with BMV. As I say, just over a matter of a few months, we've managed to get that live across all of the inpatient areas. There is a need for quite intensive ward-based support during that live period, but a lot of that ward-based support is with the clinical teams that are involved in the implementation, rather than specifically the IT teams. I think that would be fair to say. So the challenges that we've had, it's been a little bit difficult thinking back to what some of the challenges have been and how we did this, with it being so long ago. You know, you're talking about a project that was 13, 14 years ago. I think it's fair to say back in the time, getting the consultants engaged in the process was quite a challenge, and there are some people that just like the way they work and didn't really necessarily want to make that change. I think we've probably got better consultant engagement now, who realise the value of what the IT system can bring, but back then, 14 years ago, this was a massive step that we were taking forward and getting their engagement. I think some of them were quite happy to be a bit like ostriches and just put their head in the sand and think it would go away. It was very difficult, as it always is, to release staff for training. And there's the difficulty of, by the time you get round everybody to do training, the people that you've trained originally feel that they need more training because they've completely forgotten what was said originally. And I think that's probably why more recently we've taken more of a cascade approach to the training and had a lot of super users training further people on the wards, which has worked out reasonably well. Specialty prescribing was a little bit of a challenge in particular areas, as I mentioned, in neonates and intensive care, where things are just so much more specific, that it took a lot longer to move across with some of those areas. And paediatrics, again, with the very weight-based prescribing, took a little while to get up and running. We had issues with wireless connectivity. Certainly, all those years ago, we had more wards that were in very older areas of the hospital that the wireless connectivity wasn't quite so good. And I don't think that we'd really appreciated that before planning to go live, and we just found that some of the laptops would just lose their connection as the nurses were at the bedside, so we needed to address that. Variable dose medications did cause us some challenge, and still do go on to cause us some challenges, things like warfarin, insulin and other infusions that we're just busy in the process of improving at the moment and getting those exactly right, but they can be quite a challenge. So from a lessons learned point of view, we certainly learned that good clinical staff engagement really helps push the project on and actually get the clinical staff to lead on the project itself and the training and the support. And as I say, that's how we roll out an awful lot of the implementations that we've done since. You do still need to have that resource available to support the teams and then to do some of the monitoring afterwards, so that we can look back and see how much of an improvement these projects have actually made. At the hardware availability and the choices of that are something that we've learned about, just as, you know, how many laptops are required, whether it is laptops you need or actually sort of fixed computers in which locations do you put them in. And certainly with the BMV, we found that the nurses in some areas that are using drug trolleys still, it's quite difficult to pull around a laptop on wheels whilst you're also navigating a drug trolley around. So actually getting a piece of kit that combines the two of those has been invaluable in some of those areas. Drug storage as well in the medicines management is something that really helps. A number of the areas have drug cupboards at the bedside that can store the patient's own medicines and medicines that's specific to them. And we've got a team of pharmacists with a pharmacist based on every ward who's responsible for medicines management. And that does make things a lot easier and a lot slicker, and somebody there who can help the nurse and staff when they're administering, come across with any of the challenges of, say, drugs not scanning in and etc. The other lesson learnt really was around the time period between training and go live, and as with all of these things, sometimes you plan a go live date and it gets put back, but actually that makes the staff very nervous that they've forgotten the training they've had. There's an element of, yes, you need the training, but you then need to start using the system straight away so that you can learn even more while it's fresh in your mind. So we try wherever possible to do so. And different training methods can have different results, and certainly if we bring in all of the staff in and training everybody ourselves within IT, you're absolutely sure of what message goes out there and that the corners haven't been cut, and that everybody's doing the right thing. So whilst cascade training can be very useful for making sure the training happens in a very quick time scale and you're not having to worry about releasing staff from the ward areas, it can have some downsides as well that you need to be mindful of, really, and think through the pros and cons of both. So some of the benefits we've seen from a clinical perspective for the prescribers, the ordering strings of commonly prescribed doses, routes and frequencies is really helpful. So clearly any medicine that's in the system, excuse me, any medicine that's in the system is a medicine that our pharmacy stocks. So we don't have the issue of writing a prescription only to find later on that it's not something that we were allowed to prescribe. And all the most common dose for that medicine and the most common frequency for that medicine will pre-populate into the prescribing system that you're able to alter if need be. But actually the use of referring to the BNF and taking your time to remember, is this an antibiotic that's 3 times a day or 4 times a day? Well, that hard work's done behind the scenes for you. We've developed some evidence-based order sets, such as things like the care and the dying, order set of drugs for anticipatory symptoms. We can group those together as a bundle and prescribe them when we notice a patient approaching end-of-life care, so that all of those medicines are sat ready and you don't forget it. Equally so, the other good example of that is if somebody comes in having alcohol withdrawal problems, and the group of, you know, Pabrinex and other things that would all be prescribed together, there's just no need to go and try and remember what each of those are together. You can see them there as a bundle. And the majority of prescribers have set up a list of favourites, so within their own clinical area, things that they use regularly, they just populate their favourites list. So they'll come up with a list of 20 to 30 drugs that they commonly prescribe for their common reasons, with all of their preferred frequencies and doses. Means that they can be quite slick at prescribing literally in a matter of minutes. The decision support based prescribing again is there, and one example of this may be in oxygen. If you notice a trigger for saturations, this will populate to ask if you want to consider prescribing oxygen, or a set of investigations. If you're ruling out a PE, it will give you a prompt to prescribe your dalteparin for that patient while you wait for the investigation. There's a little icon where you can click when you put the prescription in. So if you do want to link to the information that's from the DNS again, rather than going and finding the book and looking it up, it's available to hand to prescribers, which is very useful. And the conflict warnings for allergies and interactions, and again duplication, is very helpful to put up, if not quite frequent. We've got that set to moderate and severe allergies rather than all of the mild allergies, as you end up getting a little bit information overload if they come through too frequently. Remote prescribing is really helpful. So if doctors are at front of house looking after patients that are coming straight through the door, but a ward is back of house phone needing a new prescription doing, they don't need to leave what they're doing and walk to the other side of the hospital to go and prescribe something. They can do that from wherever they are, and it will automatically link through any lab results at the point of prescribing, such as if they're prescribing warfarin, they can click on a button which shows them the most recent INR results. There's access to a full medication history, which you can see from medicines that have been prescribed on the system before, but there's a button for access to the MEG that can pull the information through from the GPs to give a full list of all the medicines that are prescribed out there in the community, that have hopefully just been updated since they've last been in as well. We've been able to put in some rules with the prescribing, so we have mandatory stop dates for things that, say, a course of antibiotics for 7 days, it will automatically stop at the end of that point. And a number of questions about clinical indications. So again, antibiotics is the perfect example where we need to report on what sort of infection it was. That will be a mandatory question for the prescriber to make, to ensure that we can collect that data at the other end. From a nursing point or an administration of medicines, the biggest advantage is that the prescriptions are just completely unambiguous, and you're not trying to read writing that you're not sure about. Things are spelled correctly, and you can clearly see how frequently this should be given. There's not a different language between different prescribers who use different sort of mnemonics and things for the prescribing. It is set and as I say, unambiguous. The remote prescribing is something that the staff really liked when we first went live with the electronic prescribing. It's just the responsiveness for the patients. If you've got a patient that's in pain, you want to be able to ring the doctor and get that medicine prescribed very, very quickly. There's nothing more soul destroying than telling the patient in pain, I'm really sorry, the doctor's busy, you're going to have to wait till they come over. So that's been a huge advantage. We think there's been an awful lot of time saved just from people trying to locate where the paper prescription's gone. They're not hunting through the doctor's office, through the case notes, the end of the bed, the clinical room to find where the last person's left that. And the ability to link the patient assessments with the medicine. So again, with pain is a good example. If the nurses are filling in pain scores and looking at their observations, they can link to see when the patient's last had an analgesia administered to assess how responsive that's been. The verification of the patient and medications using the barcode scanning is something that the nurses feel has really improved the safety aspect, and just having that reassurance that this is the right prescription, this is the right patient. So they do like it for that reason predominantly. And we also have a number of nurses that will administer drugs using a patient group direction, and we have the ability to document that within the system as well, but restricted just to the nurses that have undergone the training to allow them to do that. From a patient perspective, again, the remote prescribing is the thing that probably comes out highest with reduced waiting time for drugs. That's also waiting times in pharmacy. If a medicine is unclear on the prescription, the pharmacist would have to track down that doctor, and the patient is all that time waiting, trying to find out what exactly was after and get that corrected. So that can be incredibly time consuming. There's been a clear reduction in the administration errors, which from a safety point of view obviously is great for the patients, and better medicines reconciliation on admission, so we can see all of the different medicines that the patient's on and work out if indeed all of them do need continuing that admission. Given that certainly the electronic prescribing element was done so long ago, I think the formal evaluation of that probably wasn't done as well as we would have planned to do it now. It wasn't done with the purpose of looking at an initial pre and post implementation. So a lot of the information that we have is very much anecdotal about how much value that's actually given us. So certainly if we were starting afresh now and moving from paper to electronic prescribing now, that's something that we would have a much clearer plan to be improvement. Moving forward with BMV, evaluating that and looking at how that's frequently used and what sort of errors we've improved is something that we'll certainly plan to do in the coming months. But we do know that the system allows us that enhanced reporting that we can use for clinical audits. So we do feel we can get a better understanding of the medications that are missed, the reason that they're not administered. Is this just because of stock availability, or was it for a good clinical purpose? We can monitor much better antibiotic usage. And then with BMV, we can clearly monitor whether something's being scanned or not scanned. And actually, we can look at how often an error message is given to the staff. And whilst that's great that the errors are picked up and not processed through, we can actually look at the amount of errors or the amount of near misses that are picked up to ensure if there are specific issues with practice that we can go back and look at those areas. So in conclusion, it's clearly been a lengthy process to get where we are now, with a lengthy initial startup with the electronic prescribing, and then a long gap before we've moved to the next step with the closed loop system. We think that the system is particularly useful and capable to put a lot of specific restrictions in and usage, which has been quite helpful, and it can greatly enhance the functionality of the current system. But really, I think the overarching sort of bit to the conclusion is around staff engagement, and the clinical staff particularly, that really is key to the success. So I'll just hand you over to Helen now, who's going to do a quick demo of the BMV system.
Hi, I'm just going to come out of the presentation, just go into our test system. Just bear with me for a second. I'm just going to log in as a nurse. This is just one of our standard nurse menus, just so I can pick up one of our test patients. Okay, so this is just taking us into a status board, which is similar to the one that the nurses on the wards currently use. Basically, we can pull lots of information on here that we want to kind of push to the nurses in relation to sort of medications which might be next due. We're in the process of implementing the transfusion administration record, so it could show them sort of like the progress of blood transfusions. And we're also looking at the additional functionality that we have for IV infusions as well. So various things that we can flag on here. So I'm just going to open up one of our patient records. And what I'm going to do is show you a little bit of the prescribing elements, but also the administration as well from the BMV perspective. So whenever we open up the patient record, on the right-hand side here, we can see we've got a number of different buttons, and this forms our electronic medical record. So whoever's accessing the system, wherever they're accessing the record from, whether it's in clinics, in the emergency department, on the wards, they always have access to this information on screen, so they can view lab results, documentation, clinician documentation, and so on. So I'm going to jump into orders first, and just show you from the prescriber's perspective. We do have a full history, as Mel mentioned, about the ability to be able to see past medication history. So this is currently showing me the current medications the patient has for this admission, but I can actually jump back and see all of the additional history as well. Obviously, these have just been put on this month, so there's not a great deal of information here. But certainly for a patient who's been in a while, you would be able to see sort of discontinued medications. We can also see in the electronic medical record what a patient might have had on previous visits as well. So we can jump to the All Visits button, and we can see obviously this patient's had quite a lot prescribed from training sessions that we do. I'm just going to jump back to orders. I'll briefly show you the order set that Mel mentioned. Just as a quick example, you can see we've got lots of different sets. We've got combinations of lab sets, but also prescribing sets. But just to give you some examples of how much simpler it would be to pull those through. I think this one's predominantly orders, but one of that. You can just see it's pulled all of the different tests through, but that could be a combination of tests and medications for a particular condition that the patient might have come in with. So I'm just going to come out of that one, and I'm going to go back to the med. Okay, so I'm just going to prescribe some codeine for the patient. And I don't know if you may have noticed at the top here where we've got all the patient details. Somebody's recorded that this patient is actually allergic to codeine, so we should see that allergy conflict through the prescribing process. So I'm just going to go with the 30 milligram tablet. And we can see there the order strings that Mel mentioned, where we've actually got two options here. We've got an as required up to 4 times a day, and then we've got a regular 4 times a day as well. So it just means that the doctors don't have to enter all of that information themselves. Mel also mentioned the medicines information being available. So if I click the little monograph icon there, you can see all of that information on screen. So that will be available for the majority of the medications in the system, and it's regularly updated on a monthly basis. So I'm just going to select the regular medication. Now, depending on the time that the prescriber is entering this, based on the time that the medication is due, it'll ask them whether they want a dose for now or whether they just want to start it at 6 o'clock. I'm just going to say that I want a one-off dose now, but then I'm happy for the next scheduled dose to be 6 o'clock. If it was a little bit closer to 6, when I was prescribing, I could choose to select and start it at 10 o'clock. So there is a little bit of flexibility in terms of the times that it can be prescribed for. Okay, so I don't actually have to do anything additional to that because of the order string, but if I did want to add anything or change anything, I could go into the edit functions and do so. I'm just going to come back out of that. Okay, so it is at this point that I get that conflict. So it said we'll just look at sort of like intermediate and severe reactions, but there are other conflicts that we use as well. So interactions, contraindications, things like that, they will be alerted. We can also put rules in here as well. So at this point, if I hadn't entered a stop date for an allergy, it would prompt me to do so. So we have 3 options at the bottom. We can replace it and prescribe something else. We can just erase it and not do anything with that. But we also have the option to override. So I'm just going to override that for now. But the prescribers are forced to make a comment as to why they've actually decided to override the warning. Okay, and then I'm just going to save that. Okay, so it's added that codeine onto the list of current medications. So I'm just going to jump into the medicines administration record, which is where the nurses would go to administer. So that's accessed with a PIN, so every user has their own individual PIN. And this is pretty much what the prescription chart looks like. So there's lots of different functions that we have within this. So I'll just quickly go through some of the things that we have that we use on the wards currently, and then I'll go through the process of doing some medicines and the patient scan. So the nurses from the administration side, they have access to that medicines information as well. So I can click onto the monograph and see that as we did with the prescribing. We also have the ability to add comments as nurses. So if the patient has got any specific requests about medicines administration, we can just put that information in there, and that displays on the prescription as well, so we can see that clearly. We briefly mentioned oxygen prescribing. So we have a protocol whereby the nurses can start the oxygen as per the prescriber's instructions, but then they can adjust the rate of the oxygen depending on the patient's stats. So we can attach protocols. So that's just built by us. We can attach any medication protocols that we would want it to do. And then because there's certain information we would want to be recorded at the point of changing the oxygen, or it might be for other medications where you might want to record vital signs prior to administration or pain scores, you can also build assessments to capture that information, and that can be made mandatory, so you're always capturing things like the SAT, whether the nurses have changed the flow rate, etc. Obviously with this oxygen as an example. We can also associate other data that is recorded in the system. So as an example with warfarin, we would want to associate INR results. So this test patient doesn't have any, but we would be able to do that in the live system with real patients. So it would flag the last INR result. And you can choose which medications you want to associate to which lab results in the system. Okay, so what I'll do now is I'll just go through the process of actually verifying the patient and then scanning a couple of medications. So we have a wristband which has barcodes on for both patient's hospital number but also the visit number. So when you scan the patient, you're actually making sure that it's the right drug, not just for that patient, but also for that particular visit. So if I just scan the wristband, what should happen is that it tells us that the patient is verified at the top of the screen. So that's my verification that it's the correct patient and the correct prescription. If we then go to scan one of the medications, I'm just going to use the alpha-calcium here as an example. We can see this was scheduled for 12 o'clock. It's telling us that it's a little bit overdue. But if I scan that now, just warned me here that it is a little bit overdue, so I can choose whether I want to continue or not. So I'm just going to say yes to that. And because that's one tablet, one scan, we can see it's put in the dose, the time of administration, and it's also telling me with the little icon there that that has scanned successfully. I'm also going to go with another example just to show you, because it is set up currently for the unit dosing. So with the paracetamol, because that's 2 tablets, that is going to require 2 scans. So you can see here that it's telling me that the ordered dose is 1,000 milligrams, and then that's under by 500. If I scan that again, it will just warn me again that it's a little bit late, but now it's telling me that that equals, we've got the correct dose being documented there. The nurses can manually adjust doses as well, so if it was, say if 2 tablets were prescribed, the patient only took 1, we could still document that has been the case. So just okay to that. So again, it's shown us there that that has successfully scanned. So I'm just going to click OK to that and then save it so I can show you the medication history. If I look at the detail for that paracetamol, you can just see some of the medication information on the first screen. But if we look at the full history there, we can actually see that the medication has been scanned and the verification of the patient is done by scanning as well. So we have got that full log, and we can report on scanned versus not scanned. We've also got the date and time of administration, the date and time of recording, and there's other things that we can capture as well. So where we have the need for 2-person signatures, we can see who that's all signed by. Okay, we do have the ability to do a manual verification of the patient. Obviously, we encourage the nurse to try and verify the patient using the scanning when we can. But should they need to, they can do a manual verification, which would just require them to enter the actual visit number for that particular prescription. We also have the ability to not scan the medication. There will be times when they're unable to scan, so they can just click to say given, and that see there we don't have the barcode, and that would obviously be logged as not scanned as well. Mel talks about sort of medications not being administered and how we can actually report on that. So if I said that I didn't want to give this particular medication, we do have the ability to create our own admin reason code, so the nurses aren't actually just putting free text comments. We can follow and monitor that quite closely. Okay, so that's just a brief run through with some of the functionality that we have. So I'm just going to jump back to the presentation and just ask if you have any questions, either for myself or for Mel.
Hi, it's Katie here from Arden. The one question that we've had through so far is just to confirm the name of the medicines management system itself.
The medicines management system, it's all done through MEDITECH. So there's a pharmacy module, so it's all kind of interconnected through the nurse and prescribing and pharmacy side of things. So we have, as Mel mentioned, ward-based pharmacists who do use the system quite extensively, so they can enter home medications in the same system, and they can do their care plans within the same system as well. So I hope that answers the question.
Great, thanks. That's the only question we've had so far, unless there's anything else anybody wants to send through by the chat function. We haven't had anything. Can I say many thanks to Mel and Helen for the presentation. It was really informative and insightful. I think it was really helpful. If any questions do come through, then we will collate those and forward them on to yourself and get those followed up. Let's thank everyone for joining us today, and I'm sure you'll all support us in extending our thanks for Mel and Helen for their time and expertise in today's presentation. The slides will be sent out to all participants over the next day, along with a link to the webinar recording. So it'd be helpful. And I think a number of colleagues, we haven't got email addresses for, Katie, have we?
Yeah, we'll send it out to the original circulation list, but if you don't think that we've got your details, you could just quickly send those through to me. That would be great, and I can make sure you're copied in.
Brilliant. And actually, this is part of a series of webinars that we're running as part of the Learning Network. So a plea to all participants that if any of you or your colleagues would be interested in sharing a project or programme of work, then please get in touch, because it's a really excellent way of sharing people's insights, expertise, and particularly their learning as much as anything else. So we'd also like to hear any feedback that you have on the webinar and other Learning Network events. It'd be really helpful. Thanks once again to Mel and Helen. Really excellent presentation. And for just to let everybody know, our next webinar is Tuesday, the 5th of December, where we've got a presentation on cyber security, the weakest link, presented by Paul Charnley, who's the Director of IT and Information at Wirral University Teaching Hospital.